And I'd like to now introduce Liz Ovens. Liz is a tissue viability specialist nurse in the UK who has a vast experience with Accel Heal and electrical stimulation. So thank you, Liz. Over to you.
Thank you, Chris, and thank you, Robin, for that very interesting presentation on electrical stimulation and wound healing and pain reduction. Just a little bit of my background. I'm an independent tissue viability nurse. My background is really district nursing and tissue viability in the community. And I currently do 2 days a week clinical role and work with industry to support education, and also work as an expert witness to provide medical legal reports for the courts. So I'm going to sort of spend the next sort of 15-20 minutes talking about sort of using electrical stimulation in clinical practice, adopting it through the use of Accel Heal electrical stimulation therapy. So I'm going to talk a bit about my experiences and the benefits of using Accel Heal, the burden of chronic wounds and the impact of that on patients and the healthcare systems, touch on international guidelines for using the therapy, clinical indications for use, how to use it, and I'll show a little short video for that, and then a couple of case studies at the end and some troubleshooting tips and hints. So I had actually used electrical stimulation prior to using Accel Heal, and I'd had quite a lot of success with it. And so about 7 years ago, I started using it for one of my patients, who I'm going to talk about a bit later. I started to find real benefits with the therapy for wound healing and also for pain reduction, very significantly in fact, and consequently started to use it more and more on a variety of wounds. So I've used it on venous leg ulcers, diabetic ulcers, arterial ulcers, pressure ulcers, and post-operative surgical wounds, and probably noted about 90% improvement in my patients, and that's ranging from complete healing to reduction in wound size, pain reduction, and reduction in exudate. Really, it's got limited contraindications, so you can use it for the majority of your patients with complex wounds. It's very easy to use, as you'll see in the video. It's readily available in the UK. We can prescribe it on prescriptions and also order it on from our supply units. Because it's so compact, it's easily stored, it's not reliant on huge devices that need to be rented and storage and consumables. And because of that, you can use it in any setting, in the community or in hospital. And it can really be used by patients and carers and clinicians, whatever suits the patient really. And I just feel it really provides the opportunity for patients to change their lives and give them hope. And hope's really a factor in these poor patients who've often been suffering these wounds for many months and even years, and to manage their pain. And cost effectiveness has really been demonstrated, and there is some economic studies to demonstrate the effectiveness of using the therapy, and this is usually seen in reduction in nursing time and dressings. So we all, I think, appreciate the burden of chronic wounds, and they are a huge burden to patients particularly, and the number of these wounds are increasing, and that's been demonstrated in the literature. We have an increasing ageing population, so these wounds are going to continue to increase. They have a huge negative impact on patients' quality of life. You know, many patients endure pain. Pain is often the most difficult factor for these patients, and that often results in sleep deprivation, depression, and social isolation. We know that pain actually inhibits wound healing physiologically, but it also prevents tolerance to gold standard treatments, as Robin was suggesting earlier. So we often can't apply compression therapy, and very frequently can't offer debridement therapy as part of our wound bed preparation. We know that the effect of systemic analgesia has on patients. They can often have many side effects, and sometimes they have little or no effect. Many of our patients actually don't really want to take these analgesias, certainly anything stronger than a paracetamol. And as we've said, that wound care is a huge burden on our healthcare systems, with costs growing, and I'm not sure how it is in Australia, but certainly in the UK we've got a reducing workforce, so we really need to think about how we can move these wounds forward quicker. So the use of electrical stimulation has actually been recognised globally in terms of its use. So it's been recognised by the European Wound Management Association for use in a variety of wounds, as you can see, and also by the International Guidelines for Pressure Ulcers Management, and that includes the Pan-Pacific Alliance, and they've actually recommended its use to be considered for recalcitrant pressure ulcers categories 2 to 4, and that's on a very high evidence base. So as I say, it can be used on a wide variety of wounds, and the wounds that are really failing to heal or have become stagnant, and really patients who've got pain that's not managed or it's restricting their mobility, and patients who can't tolerate their gold standard treatments such as compression therapy. So just an overview, as Robin was saying, this is a 12-day electrical stimulation therapy. It's worn continuously by the patient for the 12 days, and it consists of the 6 48-hour devices, and then the therapy finishes after the day 12, but the wound will then continue to be managed using standard wound care therapy, and I'll talk about how what you'd expect to see in the wound progression during that period in a minute. I'm just going to show you a quick video now of how
this instructional film is intended to demonstrate the application of Accel Heal alongside compression bandages. Our process starts once the primary dressing has been applied to the wound. Make sure you have everything ready and close to hand to ensure an efficient dressing change for your patient. Prior to applying Accel Heal's electrode pad, ensure any excessive dry skin is removed and avoid using emollients. The selected area needs to be cleaned with the wipes provided within the treatment pack. This preparation will ensure a good adhesion of the electrode pads. Apply the Accel Heal pads as close as possible to the wound site on healthy skin either side of the wound, but ensure the pads are applied away from the area covered with the primary dressing. If the wound has excessive exudate, place the pads horizontally to avoid the pads becoming too wet from gravitational moisture. You are now ready to apply compression bandages. Follow the manufacturer instructions for applying the compression, ensuring that the electrode wires are fed through the compression bandage and not in direct contact with the skin to avoid any pressure injuries. Once you have completed the compression, you are ready to connect the device to the electrode pads. Connect the treatment device to the electrode pads by pushing the electrode connectors into the electrode pad receptors. Activate the treatment by pressing the on-off button down for 2 seconds. Secure the wires and device with tape at the top of the leg away from the tibial crest and secure with a tubular stocking net. Each device runs for 48 hours, after which time it will switch off automatically and will need replacing with a new one, which can be easily accessed without disturbing the dressing and compression therapy. The dressing and bandages can be changed according to clinical need and local policy. The electrode pads are disposed in clinical waste alongside the dressings. The device needs to be disposed of in a WE recycling facility. The treatment consists of 6 48-hour devices, making it a 12-day treatment course. The Accel Heal therapy delivers repeated treatment sessions with a resting period, which are repeated throughout the 12-day treatment period. Further instructional videos on device change and troubleshooting are available. This instruction.
So as Robin has already stated, Accel Heal actually delivers a pulsed current controlled electrical stimulation therapy. And it's actually current controlled in the fact that it actually monitors current flow through the electrode pads, and this therefore automatically adjusts the voltage to ensure the exact current that's needed in that program is delivered to the wound. And that's regardless of any variable. So we know all our patients are very, very different. They have different skin tones, they have different skin texture. It depends on the level of hydration of the skin and the patient. And very importantly, the distance between the electrode pads. And that's particularly important in different wound types and awkward or difficult to treat wounds on the, for example, on the sole of the foot. So I'm going to just show you a few examples of placement of the electrode pads on particularly foot wounds where we need to potentially avoid pressure from the electrode pads, very importantly from the wires. And so with the fact of the device being current controlled, we can actually place the electrode pads a little bit further away from the wound edge than you may consider normal. So in fact, you can see on that patient there, we've got this patient a wound, extensive wounds to the dorsum of the foot extending round to the underneath the toes there, and I've placed the electrode pads on the dorsum of the foot. And this patient, actually, we used the therapy for pain reduction, and it had a huge impact on the patient. He was able to go back to work. So just a couple of more examples coming up about how to place the pads on your wound. So you can see there wounds to the dorsum of the foot, to the heel. You can place it on either side or below the malleolus. Try to avoid applying to the actual bony prominences if you can. Toe wound, lateral aspect of the foot, a wound to the lateral plantar. So you can see I've put the pads there on the dorsum of the foot. It will still enable the electrical stimulation therapy to work on the wound. This is just showing the compression therapy being applied. You can see, as the video did, you know, the wires being placed through the bandage layers and then secured at the top of the leg. Just ensure that the device is placed away from the tibial crest bone. Just a little pointers around using the interface. So when you actually activate the treatment, you press the button down 2 seconds, and you will find a little green LED operating every 2 seconds, and that means it's operating normally. If it starts flashing very slowly, then it's in the normal resting phase that Robin also talked about. If there's no flashing, then it means that the treatment is potentially completed, or it's in pause mode. It's been the treatment's either finished or the 48-hour device has come to its end. And if it's flashing very fast, to, you know, more than twice as per second, then there's a poor contact between the electrode pads and the skin, and that may mean you need to press the electrode pads a bit more firmly on the skin, or remove the electrode pads and clean the skin again and reattach new pads. Just a couple of little warnings. It is obviously an electrical device, so ensure the device doesn't become wet. It can be removed for short periods if the patient wants to shower. Don't use the device for children under 18 years of age. And if the patient's having any other investigations, ECG or EEG, then remove the device as it may interfere. So what to expect when you're using Accel Heal, as I say, so it runs for the 12 days. You'll start to see some cellular changes within the wound and reduced inflammation. This leads to pain reduction and edema reduction. And although the exudate may increase initially, this will start to reduce. And then this wound will start to generally sort of clean up. You may start to see some wound progression, some wound contraction. That does depend on the wound size, of course, and also on the longevity of the wound. And once the 12-day treatment is completed, then you will continue to see that progress, that hopefully the pain will remain reduced and reducing, and the wound should continue to heal in its normal wound healing trajectory. If the wound becomes stalled again, or if there's some untoward event with the patient, you know, if the wound becomes infected, or there's some unstable diabetes, for example, with these patients, then you could consider using a second therapy. And certainly if that's been quite effective in the first treatment. So this is my first patient I used the therapy for. She had a venous leg ulcer for over 2 years and couldn't tolerate any compression therapy. She had small vessel disease, so we used the therapy really to try and use some compression. Within 7 days of using the therapy, the pain came from 8 out of 10 to 5 out of 10. And within 3 weeks, the wound started to improve, and the pain continued to reduce, and the wound was healed within 20 weeks. She's a 93-year-old lady, so we were absolutely delighted with the progress, and so was she. Just going to very quickly, if I've got time, to show you 3 examples of using the therapy in different patient groups. This is a recurrent venous leg ulcer. I used it for 3 patients with recurrent venous disease to try and see how it would work in terms of prevention of recurrence. This was his 3rd recurrence, despite wearing high compression therapy, and the wound had kept recurring within sort of 3 months of previous healing. He had no improvement with compression therapy, and the pain score was 10 out of 10. So we started to use the Accel Heal, and really within the 12-day therapy, the pain score came right down to 1 out of 10. There started to be changes in the peri-wound skin and improvement over the 12 weeks, and the wound closed after 16 weeks. He actually felt that the wound felt really well healed and that he could endure hot showers again, because he'd actually have warm showers prior to where previous healing had occurred. So he was very happy. This patient I used the therapy for to reduce the pain solely. She was 50-year-old again with a recurrent venous leg ulcer. She'd had several antibiotics. I couldn't even do a wound swab for her. The pain was, she was crying in the pain. And we couldn't do a Doppler assessment or put any compression therapy on. She had trying biphasic sounds. The wound was 7.5 centimetres square with some slough. So we actually used the therapy just to try and reduce the pain to facilitate some compression therapy. And the pain came right down. In fact, she reported to me that the pain improved that same day. She actually managed to reduce her tramadol the same day as we applied the therapy. And then the wound went on to heal a few weeks later. We were able to put some compression bandages on, and she went on to use some hosiery. And she was absolutely delighted because previous ulcers had taken over 6 months to heal. And then my patient with her arterial ulcer, 75-year-old recurrent ulcer to her dorsum of her foot. She had quite a punched out wound. You can see there keloid scarring, no advancement of the wound edges, and her duplex scan showed significant stenosis to the femoral artery. She had a high pain score of 8 out of 10. She initially declined the Accel Heal therapy because she wanted to use some other dressings, but we then did gain consent and we started the therapy. And within 5 days of commencing it, the wound pain reduced to 0 out of 10, and the wound started to improve. You could see softening of the tissue there. The keloid scarring started to reduce, and the tissue became much softer, and the wound went on to complete healing within 9 weeks of starting, and that was before she had her vascular intervention, which she had the following month. So really my tips and tricks for using the therapy, as Robin said, you can use it alongside most other wound treatments, including compression therapy, negative wound therapy, your antimicrobial therapies. The only treatment I would suggest not to use at the same time is larvae therapy, because of course it does, they do discharge a lot of exudate. Just ensure you provide really good skin care before you apply the electrode pads, and avoid using emollients until after application, just so you get a really good adherence of the pads. When you're putting the pads on wounds that have got a lot of gravity, a lot of exudate, avoid using the electrode pads below the wound. Sort of put them on either side of the wound as it showed on the video, and also place the pads to avoid any risk of injury from the wires. I find if I increase the dressing layers or increase the dressing changes that first week, because it does tend to increase exudate a little bit in the early days, but that will soon tail off. As I say, it's very easy to use for patients. And I've also found that I've applied it to wounds, that the larger wounds or the most chronic wounds first, when patients have got multiple wounds. You may find that the other wounds may improve. And in fact, I've had wounds on the other limb that have improved, in fact, just from using the therapy on the one leg. So consider using for wounds that have not improved, that are stagnant, patients with pain who are unable to tolerate standard therapy, compression therapy, patients with general uncontrolled pain, and patients potentially with recurrent wounds and all at high risk of becoming stagnant and failing to heal due to other comorbidities. So it is a very easy to use, pre-programmed wearable single-use device. As Robin said, it's subsensory, using an effective waveform, and it is used alongside current topical treatment, which is important for patients. They like to often continue with what they've been having in the past. It's off the shelf, there's no expensive kit or training required, and cost effectiveness has been demonstrated in faster healing, reduction of dressings, and reduction in nursing time. And very importantly, it relieves the pain, it stimulates the healing process, and it really improves patients' lives. And that's really important for all of us. So I'd like to hand you back now to Chris,